Thank you, Dr. Kazmi. That was really very informative. I'm going to move into my topic now, which is challenges in lung cancer treatment, with a focus on disparities in healthcare. By way of introduction, I am an associate professor in the Division of Hematology and Medical Oncology at Donald and Barbara Zucker School of Medicine at Hofstra, Northwell Health. I focus on thoracic malignancies. These are my disclosures. So with regards to lung cancer disparities in incidence, mortality, and diagnosis and treatment, there are really several factors that one could consider. The most important ones, I think the heavily studied ones, are race, ethnicity, and socioeconomic status. But then there are religious, political, geographic, age, gender, stage of cancer, histology, patient-centric factors such as their own beliefs and trust issues, physician-centric, conscious and unconscious bias, comorbid conditions, having a support system, and insurance status, which I guess could be tied with socioeconomic status. There could be overlap in many of these factors, but individually these factors could be quite influential in how patients present and their mortality, diagnosis, and treatment. So lung cancer statistics, this is not new. This is a little outdated, but still, you know, an estimated 200,000 plus new cases every year and 155 plus deaths from lung cancer in 2017. 80% of these are associated with smoking. 1 in 7 smokers die of lung cancer. Deaths from lung cancer is more than that from prostate, breast, and colon cancers combined. So predominantly it's non-small cell, but there's about 13% to 15% of small cell. And even after all these years, the 5-year survival for lung cancer currently is at 15.6%, compared to over 90% for breast cancer, colon, and prostate cancers. 5-year survival for advanced cancer is less than 20%. This is a little outdated data, but still, it's still in low two-digit range. So these are the trends in cancer deaths amongst females. I just chose this for an example, but you know, as you can see, the lung cancer incidence peaked, the lung cancer mortality peaked, and then thankfully it is coming down. And other cancers are also listed, how they compare with the thoracic. And this kind of parallels with general population and the male population as well. But how about African Americans? The data for African Americans is it's very interesting, and it's variable based on different reviews and different publications. But in general, in this figure, the dark bars are represent African Americans, and the shaded bars represent the Caucasian population. So as you can see, at each age groups, the incidence of lung cancer is higher. This was data from 2001, and then after the age of 75, it kind of levels off. This is probability of survival. The dotted line is all comers, all general population, and the straight line is that of the African American. So as you can see, the probability of survival is significantly lower in African Americans. And that is even more significant when you go, when the cancer is more advanced. And this data is from 2002, and it compares, this is how it compares with general population. The dark line is that of non-African American, and the dotted line here is of African American population. So the same theme again. So over the years, this is more recent data, and as you can see, over the years, the mortality in the overall population has leveled off, But still in certain populations, as I've circled here, in the male Black patients, the incidence of lung cancer is significantly higher compared to whites, and the same thing with mortality. So still a large disparity in lung cancer incidence and mortality in these special populations. So this is how it compares with other diseases, and this is with regards to disparity related to the type of insurance. So the blue line represents private insurance. The dotted dark blue line is that of Medicaid, and the dotted red line is that of uninsured. And if you can focus on lung cancer, as you can see, the survival is significantly higher for patients who have private insurance compared to those who have other types of insurance, Medicare, Medicaid, and uninsured patients. So the socioeconomic status also makes a huge impact on how lung cancer patients fare after their diagnosis. So what, over the last decade, I think one important aspect that has really changed the lives of these patients is lung cancer screening. So the low-dose CT has become standard of care practice for primary care physicians, and this was through the NLST, the National Lung Cancer Screening Trial, which showed that low-dose CT can detect twice the number of lung cancers compared to chest X-ray. And it also came with a mortality benefit, so 20% relative reduction in lung cancer mortality. There was greater reduction in lung cancer mortality amongst the Black patients with a hazard ratio of 0.61. It was not significant, but guess what? Out of the 53,435 patients enrolled in this study, 48,549 were white patients. So only 4.4% were Black. So it was clearly an underrepresented population. And even within that, there were some signals that this intervention could have a huge impact on the mortality of these patients. So hopefully future trials will look at this specific population and other minority populations and be able to assess the impact of lung cancer screening. We know lung cancer screening works. The Nelson study, which was a study in Europe, showed that there was a 26% reduction in mortality, and even higher for women, 39%, another population that is relatively underrepresented in a lot of studies. So what about geographic? It's a global issue. We know that when we talk about disparities, we talk a lot about global issues. There are developing countries which do not have access to screening procedures and to treatments. But even within US, depending on the geographic area that a particular person lives in, there are huge differences. As you can see here, this is the map showing the percentage of enrollees aged 55 to 77 who underwent low-dose CAT scan screening in 2017 by state. States are kind of color-coded here, and you can see that there are some states where the rates are up to 15%, and there are some that are as low as 1%. So this actually gives us an idea as to who are these patients, and because the previous one that I just showed here, this is just per 1,000 patients, 1,000 people in that particular geographic area. But did they qualify? Is it possible that these people never qualified for lung cancer screening and that's why they didn't get the screening procedure? So this kind of answers that question. Here on the y-axis, you have the number per 1,000 of the enrollees who underwent low-dose CAT scan. And on the x-axis, you have a number of patients per number of subjects per 1,000 of state residents aged 55 to 77 who reported as they were current smokers. As you can see on the left-hand side, states like Utah and California, where the incidence of smoking is low, also had low number of enrollees for low-dose CT. That is appropriate. But on the other side, states like Louisiana, West Virginia, Arkansas, they were heavy smoking population, but very few of them were actually enrolled in the low-dose CT. So there's a large gap here and a lot of room for improvement. Why is it important? Because we know that if lung cancer is caught early, it is highly curable. So this, the top pie chart tells us the current representation of individual stages with regards to non-small cell lung cancer. So localized lung cancer confined to the primary site is about 16%. Regional, when there is spread to regional lymph nodes, is about 22%. And distant disease is 57%. And 5% in this particular study was unknown. But on the flip side, when it's localized, the survival is much higher, so 55.6%, as against distant, where the 5-year survival is like 4.5%. So it's very important to catch the disease early, and lung cancer screening would be the best way to do that. Is it possible that surgery in these patients in African Americans may not be as helpful as white patients? That's not true, because there are studies like this one that have shown that the outcomes are identical both in whites and blacks if they undergo surgery compared to those that don't undergo surgery. So the top figure here shows the number of patients. The blue represents Black Americans, and the red represents white Americans, and the green is difference in the two groups. So the first one is about surgery. So fewer Black Americans undergo surgery for the same stage of cancer, same type of cancer, MASH cancer, compared to white Americans. And you can see the difference is significant. The next graph is that of radiation. That seems to be somewhat equivalent, and you can see that there's not much difference between the two populations. C is that of no treatment. More African Americans receive no treatment for their cancer or alternate treatments for their cancer compared to white Americans. This is significant. This is the disparity that we are focusing on today. And this is another study that was published in JCO in 2006. This recorded the reasons as reported in the SEER database as to why surgery was not performed for these patients and stratified by white and Black patients. So as you can see, surgery was not recommended for more Black patients compared to white, and that was significant. And it was contraindicated actually for more white Americans than Black. So this disparity is quite striking. This is a very busy slide. I really don't want to focus on a lot of things, but I just want to say at every, for every parameter, the fewer Black Americans received surgery. Patients with more than 2 comorbid conditions almost never received surgery compared to those compared to white Americans. So this is a large database study. The NCDB is quite it's a really trusted database, and this particular study looked at over 1 million patients who selected about 18,000 of those who had non-small cell lung cancer with NET stages and N1 disease, and looked to see how many of these patients underwent surgery only and how many of them received adjuvant chemotherapy after surgery. So as per the guidelines, guideline appropriate treatment would be adjuvant chemotherapy for this population, node positive population. So in a nutshell, this particular study looked at disparities in guideline concordant treatment for pathologic N1 non-small cell lung cancer. And they specifically looked at disadvantaged socioeconomic status groups, rural residents, and uninsured Medicaid patients. And then they studied the art of receiving adjuvant chemotherapy after surgery. They saw that patients who lived in rural resident, uninsured Medicaid patients had a significant lesser chance of having received adjuvant chemotherapy compared to those who lived in urban areas and who had had insurance. So they also had worse overall survival if they did not receive adjuvant chemotherapy, which is a known fact. So this was 54% compared to 40%. So this is Kaplan-Meier curves for all group unselected population on the top figure, and propensity matched groups in the lower figure. So as you can see, the top figure, both of them represent the KM curves are quite splayed out, and you can see that the difference is quite striking. So, you know, the traditional view of lung cancer has been with regards to the histology: adenocarcinoma, squamous, large cell, small cell. This is important for in many ways. You know, this is how we identify patients as to how we should treat them. You know, we select the chemotherapy agents even today based on their underlying diagnosis. This is the trend, and you know, for all comers over the years from 1973 till now. In the past, squamous cell was very prevalent, and adenocarcinoma not so much, and now that is the rising. It's increasing in both males and females. But when you look at different when you look at the ethnic differences, ethnic racial differences, the graphs are very different in these populations. So suggesting that there is really some biological changes that are going on in these populations that need to be carefully studied as well. But as we all know now, beyond histological diagnosis, we want molecular information, and it is really important. This is an outdated figure. Already we have many more agents since I put this thing together, but it's really important to identify the driver mutation, because there are a lot of targetable mutations, and patients can be treated with very effective agents based on their mutation status. The first example, I mean, this is for the squamous cell also. There are some driver mutations which are important, and there are some upcoming targetable mutations and targeted therapies for this cancer as well. The first one of the first studies that showed that tyrosine kinase inhibitors, oral therapies for lung cancer, was very effective compared to chemotherapy was with the EGFR mutation. The IPASS study by Dr. Mock and group showed that in patients who had the mutations, EGFR mutation, there was a significant increased responses, nearly doubling of responses, and a significant improvement in median progression-free survival, and also an improvement in overall survival. Since then, there have been several studies that have shown that several TKIs that are now approved have improvement over chemotherapy. And now we have the FLAURA data, which shows that osimertinib is superior to standard EGFR tyrosine kinase inhibitor first generation, gefitinib or erlotinib. So all this is great. We have great therapeutic options, but how is it reaching the general public? And what do we know about the mutation status in African Americans? So as you can see here, it's all over the place. They are underrepresented. We do not really know the incidence of the mutation frequency in this population. We do not know the mutation frequency in Hispanics. We do not know in other minority groups. So it's really important to, and as you can see here, the EGFR mutations in these groups, some of them were really unique to this population and really rare and of unknown significance. So really important to include more of these patients and study the mutational status of these special populations to have a more uniform assessment of the entire population. This is again with the geographic location. This was a study by Dr. Lynch and group in 2010, looking at hospitals that ordered the EGFR assay. This was the year when EGFR mutation was known, and we knew that this was targetable. And as you can see in the coastal areas, the testing was very prevalent. This was NCCN, as per NCCN guidelines. But in the central states, very few, far and in between hospitals actually ordered these tests as a routine. This has changed quite a bit now, today, but still there are a lot of differences depending on the location where the patient is receiving treatment. The further they are from a cancer center, the less likely they are to be receiving treatment based on their mutational status. So we have really had major advances in lung cancer treatment prognosis over the last couple of decades. But what is really depressing sort of is that there are increasing rates of no treatment in advanced stage non-small cell lung cancer patients. This was a study that was reported by Dr. Elizabeth David and group that was published in JTO in 2017, and there was another update this year. This was a propensity matched analysis showing that in stage 2, for stage 2, there were 15% of the patients who did not receive any treatment. That's really appalling. This is from public data sets. The same 3 with 3A, 16% did not receive any treatment, and stage 3B, 22%, and stage 4, 25%, almost 26% of patients did not receive any treatment. That is really depressing. So with all these advances, it seems like it's not reaching the patients, the general population, all patients that should rightfully get these treatments available to them. So how can we close these gaps? I think, one of the things for lung cancer screening is to work with the EMRs and to get real-time alerts for lung cancer screening. And just so that the bias and other personal issues do not come in the way of identifying patients, enabling healthcare access to communities, helping with transportation and other socioeconomic needs. Having nurse navigators has worked great with many practices. There have been several studies showing that having nurse navigators help patients get from one place to another and can reduce the time gaps between diagnosis and treatment. Educating the public directly, getting community involvement through community advisors, efforts to remove stigma. With lung cancer, one of the most common risk factors being smoking, there's the stigma, I smoked for all these years and that's why I have this lung cancer. That's a common thing that we hear from patients, and efforts to remove that stigma may go a long way in helping patients get to their treatment in a timely fashion. And having this liaison between community centers and academic centers can get patients to access to clinical trials and other therapies that are not perhaps feasible in community smaller centers. And ultimately bringing clinical trials to the community and educating providers about conscious and unconscious bias are some of the things that could potentially help in closing the gaps. In conclusion, lung cancer is it's an exciting field at this time. Lots of advances. We hear about all this groundbreaking research, and unless these are brought to the population in dire need, this is not going to be impactful in reducing the overall mortality for the entire nation. So with this, I will close and thank you for this opportunity, and I stand by to take any questions.